Hi, this is Amber Knowlton, Nursing 2212, Chapter 38, Aortic Aneurysms, Dissection, and Rupture. The aorta is the largest artery. It supplies oxygen, nutrients, and blood to all the vital organs. One of the most common problems affecting the aorta is aneurysm, which is a permanent outpouching or dilation of the wall of the vessel. Aneurysms may occur in more than one location along the aorta. Most common vascular problems of the aorta are aneurysms or aortic dissection. Aortic aneurysms may involve the aortic arch and thoracic aorta and or the abdominal aorta. 3/4 of aortic aneurysms occur in the abdominal aorta and 1/4 in the thoracic arch. This picture here is angiography demonstrating an abdominal aortic aneurysm. You can note the calcifications of the aortic wall. That's where the arrows are pointing to, an extension of the aneurysm into the common iliac arteries. Abdominal aortic aneurysms affect about 1.1 million adults between 55 and 84 years of age, and most occur below the renal arteries. You may have an aneurysm in more than one location. Aortas larger than 3 centimeters in diameter are considered aneurysmal. The growth rate is unpredictable. The larger the aneurysm, the greater the risk of rupture. Risk factors include age, male gender, hypertension, coronary artery disease, family history, high cholesterol, peripheral artery disease, carotid artery disease, CVA, tobacco use, and excess weight. Male gender, age, tobacco are the 3 most important risk factors. Aneurysms are classified as true or false. A true aneurysm, the wall of the artery forms an aneurysm. A false aneurysm is not an aneurysm, but it's a disruption of the arterial wall layers. This picture here is in your book on page 842. This is figure 38.5. Thoracic aorta aneurysms are often asymptomatic. Most common manifestations would be deep, diffuse chest pain. Pain may extend into the intercapsular area. Angina from decreased blood flow to coronary arteries. Hoarseness from pressure on the laryngeal nerve. Dysphagia from pressure on the esophagus. Jugular venous distension, edema of the face from a decreased venous return. AAAs, which is the shortening of aortic abdominal aneurysms, are asymptomatic. They're typically found on routine exams. Patients may have a pulsatile mass in the periumbilical area, and bruits may be heard. You never palpate the abdomen if you detect a pulsatile mass, because there's a risk of rupturing it with palpation. AAA pain mimics abdominal back pain disorders. It may spontaneously embolize plaque, causing blue toe syndrome. Patients will have patchy modeling of feet and toes with presence of palpable pedal pulses. Complications, rupture is the most serious complication. Patients will complain of severe back pain. It will be a sudden onset of back pain. It'll be the worst back pain they've ever had. If rupture in the thoracic abdominal cavity, greater than 90% of patients die from massive hemorrhage. Patient will be in hypovolemic shock, tachycardia, hypotensive, pale, clammy, decreased urine output, altered level of consciousness, and abdominal tenderness. Diagnostic studies, chest x-rays will show a widening of the aorta. Abdominal x-rays show calcification of the aortic wall. EKGs are typically done to rule out if the patient's having a myocardial infarction. Ultrasound for screening and monitoring. CT scan is the most accurate to determine the length and presence of a thrombus and an aneurysm. MRIs and angiography. Contrast dyes to map the aortic system. So the goal is to prevent aneurysms from rupturing. Early detection and treatment is imperative. Once an aneurysm is detected, studies are done to determine the size and location. A careful review of body systems is necessary to identify comorbidities, especially of the lungs, heart, or kidney, because they may influence the patient's surgical risk. We want to modify any risk factors the patient may have. So what of patients' risks can the patient control? They can't control their gender, their age, their history, but they can control tobacco cessation, measures to decrease their blood pressure, optimize their lipid profile, and to have annual monitoring of their aneurysm size using ultrasound, CT, and MRI. Growth rates can be lowered with beta-adrenergic blocking agents such as propranolol. Statins will be useful with controlling lipid profiles, and antibiotics. Surgery is recommended in asymptomatic patients with a 5.5 centimeter or larger AAA. Surgical intervention may occur sooner if the patient has a genetic disorder such as Marfan's, or if the aneurysm expands rapidly, if it becomes symptomatic, or if the risk of rupture is high. Correction of existing carotid and/or coronary artery blockages may be needed before the aneurysm can be repaired. If the aneurysm ruptures, this is emergency surgery. Remember, more than 90% of these patients probably aren't going to even survive to get to the hospital. If the patient is having elective surgical therapy, then we want to make sure that these patients are well hydrated, that we're monitoring their electrolytes, their coagulations, their hemoglobin, hematocrit, checking those, correcting any abnormalities before surgery. However, remember, if this is an emergency and it's a ruptured emergent surgical intervention, we don't have time to do those things. In an open repair, patients will have a large abdominal incision. There's cuts into the aorta. The thrombus is removed. They suture in a graft, and then there's sutures to the aortic wall. Endovascular graft is minimally invasive. So this is where they place a graft through the femoral artery. Complications. Can include an endoleak, seepage of blood back into an old aneurysm, growth above or below the aneurysm, dissection, bleeding, renal artery occlusion, thrombosis, incisional site, hematoma, and infection. These patients need a thorough history and physical exam. We want to watch for signs of cardiac, pulmonary, cerebral, and lower extremity vascular problems. We want to establish a baseline to compare pre and post operatively. We want to note the quality and characteristics of peripheral pulses and neurologic status. We want to make sure that we're marking and documenting pedal pulse sites and any skin lesions on the lower extremities before surgery. We want to monitor for any indications of rupture, such as diaphoresis, pallor, weakness, tachycardia, hypotension, abdominal pain, back pain, groin, or periumbilical pain, changes in their LOC, and a pulsating abdominal mass are all indications of rupture. Planning, overall, our goals are we want the patient to have normal tissue perfusion and intact motor and sensory function and no complications related to the surgical repair. Health promotion. In your book, table 34.3 lists reductions of risk factors. So examples of those risk factors include blood pressure control, smoking cessation, increasing physical activity, and maintaining normal body weight and serum lipid levels. We want to make sure that we are providing patient teaching, emotional support, and a careful assessment of the all body systems. Preoperatively, we want to briefly explain the disease, any planned surgical procedure, pre-op routine such as bowel prep, patient should be NPO, IV antibiotics before an incision is made. And then also preoperatively, we want to prepare the patient for expectations after surgery, what will happen in the recovery room, any tubes the patient might have, drains, if the patient's going to the ICU, and teaching about beta blockers, which they'll be on after surgery. Postoperatively, aortic surgery patients typically go to ICU for 24 to 48 hours for close monitoring. Adequate blood pressure control is very important to maintain graft patency. Prolonged low blood pressure may result in graft thrombosis, and hypertension stresses the surgical site that can cause leakage or rupture of the site. Drug therapy might be needed for severe hypertension. So this might be IV diuretics such as furosemide or IV antihypertensive meds such as nitroprusside, esmolol, labetalol. Cardiovascular status needs to be assessed. So MI or infarction may occur in the perioperative period due to decreased myocardial oxygen supply or increased myocardial oxygen demands. Cardiac dysrhythmias may occur due to electrolyte imbalances, hypoxemia, hypothermia, or from myocardial ischemia. All IV arterial CVP or PA catheter insertion sites should be cared for by using strict aseptic technique because they are ports of entry for bacteria. Meticulous perineal care for the patient with an indwelling cath to minimize the risk of UTI and keep surgical incisions clean and dry. After open abdominal aortic surgery, paralytic ileus may develop as a result of anesthesia and handling of the bowel during surgery. The intestines may become swollen and bruised, and peristalsis ceases for variable intervals. A retroperitoneal surgical approach can be used to decrease the risk of bowel complications. Clinical manifestations of bowel ischemia include absent bowel sounds, fever, abdominal distension, diarrhea, and bloody stools. When the descending aorta is involved, neurovascular assessment of the lower extremities is very important. As the nurse, you should check and record all peripheral pulses hourly for several hours and then routinely based on policy. When the ascending aorta and the aortic arch are involved, assess the carotid, radial, and temporal artery pulses. For surgery of the descending aorta, assess the femoral, popliteal, post-tib, and dorsalis pedis pulses. Occasionally, lower extremity pulses may be absent for a short time after surgery as the result of vasospasm and hypothermia. A decreased or absent pulse together with a cool, pale, mottled, or painful extremity may indicate embolization or graft occlusion, and these need to be reported to the physician immediately. In the immediate post-op period, we want to record hourly urine outputs. And why are we doing this? Because during surgery, there'll be occlusion of the renal artery. So we want to maintain accurate I&O, record daily weights until the patient resumes a regular diet. We want decreased renal perfusion can occur from embolization of the aortic thrombus, plaque to one or both of the renal arteries. This causes ischemia of one or both kidneys. Hypotension, dehydration, prolonged aortic clamping during surgery, or blood loss also can lead to decreased renal perfusion. Home care, these patients will be fatigued, have a poor appetite, and irregular bowel habits can be common. We need to teach them that any redness, swelling, increased pain, drainage from incisions, or a fever greater than 100 should be reported. Sexual dysfunction in male patients is common after aortic surgery. Preoperatively document baseline sexual function and recommend counseling as appropriate. A referral to a urologist also might be useful if erectile dysfunction occurs. Excuse me, let me back up here. So evaluation, expected outcomes, patient will have a patent arterial graft with adequate distal perfusion. Patient will have adequate urine output and no signs of infection. So aortic dissection results from the creation of a false lumen between the intima, which is the inner lining, and the media, which is the middle layer of the arterial wall. Approximately 60 to 70% of dissections involve the ascending aorta and are acute in onset. Here's a picture of a torn intima in the vessel wall. Predisposing factors for dissection include age, blunt or iatrogenic trauma, congenital heart diseases, connective tissue disorders, cocaine use, history of cardiac surgery, atherosclerosis, being male, pregnancy, hypertension, and Turner syndrome. Clinical manifestations are going to depend on the location of the intimal tear and the extent of the dissection. Most patients with an acute ascending aortic dissection report sudden, severe onset of excruciating chest and or back pain that radiates to the neck or shoulders. Patient with acute descending aortic dissection are more likely to report pain in their back, abdomen, or legs. Dissection pain can be differentiated from MI pain that is more gradual in onset and has increasing intensity. As the dissection progresses, pain might migrate. Older patients are less likely to present with abrupt onset of chest or back pain and are more likely to present with hypotension and vague symptoms. Neurologic deficits may include altered LOC, weakened or absent carotid and temporal pulses, and dizziness or syncope. The aorta may rupture, and this results in exsanguination and death. Hemorrhage may occur in the mediastinal, pleural, or abdominal cavities, and occlusion of arterial supply to vital organs occurs. A chest x-ray, again, may show widening of the mediastinum and a pleural effusion. A 3D CT scan and transesophageal echocardiography have become the standard of care for the diagnosis of acute aortic dissection. A CT scan can provide information on the presence and severity of the dissection. MRI does have the highest accuracy for detecting aortic aneurysms. It is contraindicated, though, in some patients with metallic implants, patients that are hemodynamically unstable. So with an aortic dissection, our initial goal is to decrease the blood pressure and myocardial contractility to diminish pulsatile forces within the aorta. Patients, an IV beta adrenergic blocker such as esmolol is titrated to target a heart rate of 60 beats or less. Morphine is the preferred analgesic as it decreases sympathetic nervous system stimulation as well as relieving pain. Calcium channel blockers, for example, diltiazem, verapamil, can be used to lower the heart rate if beta adrenergic blockers are contraindicated. ACE inhibitors, such as an enalapril, might also be used. Endovascular dissection repair is the standard to treat acute descending aortic dissections with complications. Emergency surgery for acute ascending aortic dissection. This is when drug therapy is ineffective or when complications of aortic dissection are present. Surgery is delayed to allow edema to decrease and to permit clotting of blood. Surgery does involve resection of aortic segments and replacement with synthetic graft materials. Women typically experience poorer surgical outcomes and higher mortalities than men. Preoperatively, patients should be in a semi-Fowler's position, maintaining a quiet environment. We want these measures help to keep the heart rate and systolic blood pressure at the lowest possible level that maintains vital organ perfusion. Typically, a heart rate less than 60 and a systolic blood pressure less than 120. We want to prevent the extension of the dissection, manage pain and anxiety because they can cause elevations in heart rate and systolic blood pressure. We want to monitor vital signs frequently, sometimes as often as every 2 to 3 minutes until target blood pressure is reached. If the arteries branching off the aortic arch are involved, there'll be a decrease in cerebral blood flow, and this may alter LOC. Nursing management postoperatively. Patients need to understand that antihypertensive drugs must be taken daily for the rest of their lives. So beta adrenergic blockers such as metoprolol are used to control blood pressure and decrease myocardial contractility. The most common cause of death in long-term survivors is aortic rupture from redissection or aneurysm formation. So question, following an aortic aneurysm repair, the patient suddenly develops severe pain in the right lower extremity. The right pedal pulse is decreased and the right foot is cool and pale. Which complications should the nurse expect? And the answer is D. A decreased or absent pulse together with a cool, pale, mottled, or painful extremity might indicate embolization or graft occlusion.